Welcome back to Roadmap to Residency. Today we're attacking adrenal and pituitary disorders on Step 3, the way the exam actually works. This is a strategy session, not a lecture. We'll look at the exact question stems, the trigger words the writers plant, and why the right answer is right and every wrong answer is wrong. We'll cover adrenal insufficiency and stress dosing, the Cushing syndrome workup, pituitary incidentalomas, and diabetes insipidus. Keep your question bank open and your endocrine review chapter nearby. If this helps, please like and subscribe and visit roadmaptoresidency.com for expert tutors and residency advisors. Let's get to work. Here's the plan. First, adrenal insufficiency, where the game is recognizing the stem and deciding whether the patient needs stress dosing now. Second, the Cushing workup, where the exam wants the steps in a specific order. Third, the pituitary incidentaloma, where the answer is about what you check before you operate. And fourth, diabetes insipidus, where a handful of lab numbers separate every answer choice. We'll work practice questions together and reason through every option. For content, open the endocrine chapter of whatever board review resource you trust and pair it with your question bank. Read the explanation on every question, including the ones you get right. That's where pattern recognition is built. Strategy 1, the highest yield rule in this video. When the stem describes an unstable patient with suspected adrenal crisis, you treat before you confirm. The pattern is low blood pressure that doesn't respond to fluids, low sodium, high potassium, low glucose, and a patient on chronic steroids, or who stopped them, or with another autoimmune disease. Sometimes an infection or surgery is layered on top. Once you see that cluster, your reflex is IV fluids and IV hydrocortisone now. The exam will offer a cortisol level, a stimulation test, or imaging as the next step. Drawing labs is fine only if nothing is delayed by it. Waiting on a stimulation test before treating a hypertensive patient is the trap, and it's wrong every time. Treat first, confirm after. Strategy 2 is stress dosing, tested more than any textbook would suggest. Start by asking who is suppressed. Any patient on a meaningful daily glucocorticoid dose for several weeks or longer is presumed suppressed, and the stem tells you the drug, dose, and duration. That sentence is the clue, not decoration. Then find the stressor the writer planted. Surgery, serious infection, major trauma, or a vomiting illness where the patient can't absorb the pill. Now match the dose to the stressor. A minor illness gets a temporary increase in the oral dose. Major surgery, sepsis, or vomiting means the oral route can't be trusted, so the answer is parenteral hydrocortisone. 2 wrong choices show up constantly. Continuing the home dose through a major stressor is wrong because the patient can't mount a response. And stopping the steroid abruptly is wrong because that creates the crisis. Cushing syndrome is a workup question, testing whether you run the steps in order. Step 1. Ask whether cortisol is actually high. The stem gives the classic picture: central weight gain, purple stretch marks, easy bruising, proximal muscle weakness, and high blood pressure. Your first move is a screening test that proves cortisol is elevated: late-night salivary cortisol, an overnight low-dose dexamethasone suppression test, or a 24-hour urine-free cortisol. Imaging is not the first step. Step 2, only after the excess is confirmed, ask where the problem lives by measuring corticotropin. If it's suppressed, the adrenal is autonomous, so image the adrenals. If it's normal or high, the drive is pituitary or ectopic, so image the pituitary. But before any of that, screen for exogenous steroids. The most common cause is the medication list, and the writers plant it. If the patient is on a glucocorticoid, the answer is to taper it, not order a suppression test. Look at the medications first, every time. Our first practice question. A 48-year-old woman with rheumatoid arthritis on daily prednisone for 2 years has an emergency appendectomy. 6 hours later, she's confused. Her blood pressure is 80/50 and doesn't improve after 2 liters of saline. Her sodium is low, potassium high, glucose low. The question asks for the most appropriate next step. Notice 3 things the writer handed you: the chronic steroid, the major stressor, and the refractory low blood pressure with that specific lab pattern. Pick your answer now. Let's break this down. Step 1, spot the pattern. 2 years of prednisone means a suppressed axis. The appendectomy is a major stressor, and the presentation is fluid refractory low blood pressure with low sodium, high potassium, and low glucose. That triad is the fingerprint. This is adrenal crisis, and this patient is unstable now. Step 2. Apply the rule. Treat before you confirm. The answer is IV hydrocortisone with continued fluid resuscitation. You can draw a cortisol level as the medication is prepared, but nothing waits on it. Step 3. Eliminate. A corticotropin stimulation test delays treatment in a dying patient, so it's wrong no matter how good it sounds. CT of the abdomen chases a diagnosis you already have and puts an unstable patient in a scanner. IV vasopressin treats the number, not the cause, and pressors work poorly with no cortisol on board. The correct answer is IV hydrocortisone with fluids. The strategy, not the memorized fact, got you there. Our second practice question, a workup order question. A 34-year-old woman comes in with abdominal weight gain, purple stretch marks, easy bruising, and difficulty rising from a chair, which is proximal muscle weakness. Her blood pressure is 152/94, and her glucose is elevated. Critically, she takes only an oral contraceptive and no other medications, so the writer closed the exogenous steroid door. The question asks for the most appropriate next step. Ask yourself what you have to prove before you go looking for a lesion. Pick your answer. Let's reason through this. First, confirm the excess. The stem gives a convincing picture and tells you she takes no medication but an oral contraceptive, closing the exogenous steroid door. So your next step is a screening test proving cortisol is elevated. The overnight low-dose dexamethasone suppression test does exactly that. A late-night salivary cortisol or 24-hour urine-free cortisol are equally acceptable. Why does imaging come last? MRI of the pituitary is wrong because small incidental pituitary lesions are common in healthy people, so a scan before confirming the hormone problem points you at a lesion that may be irrelevant. Measuring corticotropin is a localization step. It answers where, and you haven't answered whether. Right step, wrong order, the most seductive distractor on this exam. CT of the adrenals makes the same error aimed at a different gland. The correct answer is the overnight low-dose dexamethasone suppression test. Confirm, then localize, then image. Now pituitary incidentalomas, then diabetes insipidus. The incidentaloma stem is always the same. Someone got a head scan for a headache or after a car accident, and a small pituitary lesion turned up by accident. The choices tempt you with surgery, repeat imaging alone, or reassurance. The rule: before anyone talks about an operation, do two things. Check the full pituitary hormone panel to see whether the lesion is producing hormone or destroying the gland, and get formal visual field testing to see whether it's pressing on the optic chiasm. If the lesion is small, hormones normal, and fields intact, observe with repeat imaging. Two details force action. First, vision loss, meaning the lesion is pressing on the chiasm, which with a large lesion points to surgery. Second, a high prolactin, the exception the exam loves, because a prolactin-producing lesion is treated with a dopamine agonist, not an operation. Always check the prolactin before the operating room, or you'll pick surgery on a lesion that would have shrunk with a pill. Our third practice question, built entirely from lab values. A 26-year-old man is hospitalized after a head injury. He's producing more than 6 liters of dilute urine a day and drinking constantly. His serum sodium is high, serum osmolality high, and urine osmolality low. Then the writer gives the discriminating step. After desmopressin, his urine osmolality rises substantially. The question asks for the most likely diagnosis. Every number is doing work. The high sodium says he's losing free water rather than overdrinking. The dilute urine says the kidney isn't concentrating. And the desmopressin response tells you which half of the axis is broken. Pick your answer. Let's break this down. First, the discriminating step. High sodium with dilute urine means he's truly losing free water, not overdrinking. Then the desmopressin dose asks one question. Can this kidney respond to the hormone? It responds, and urine osmolality climbs. So the kidney works fine and the hormone was missing. Head trauma damaged the source. That's central diabetes insipidus, the answer. Now the wrong choice is nephrogenic diabetes insipidus is wrong because there the kidney can't hear the hormone, so it would ignore desmopressin and stay dilute. Primary polydipsia is wrong because those patients drink by habit, so their sodium runs low, not high. And SIADH is the opposite disease, too much hormone, so sodium is low and urine concentrated. Every distractor is eliminated by a number the writer gave you. The correct answer is central diabetes insipidus. When a stem is dense with labs, let each number kill an answer choice. Here's the pearl that ties this together, and it works beyond endocrine. Before you evaluate a single answer choice, ask what the stem wants you to do. There are two modes. Mode 1, the unstable patient. If vitals are abnormal and the patient is deteriorating, the exam wants treatment. Hydrocortisone for the crisis, fluids for the shock. Any choice that orders a confirmatory study before treatment is the planted trap, and it always sounds sophisticated because that's how traps are built. Mode 2, the stable patient. If the patient is comfortable in your clinic, the exam wants an orderly, cost-effective workup. Confirm the hormone abnormality first, localize second, image last. A choice that opens with a scan skipped 2 steps. And it's wrong even when that scan is eventually needed. Sort every stem into unstable or stable before reading the options, and half the choices disqualify themselves. That wraps up adrenal and pituitary disorders. Hold on to the core ideas. When the patient is unstable, treat the crisis with hydrocortisone and fluids before you confirm anything. Know who is suppressed and match the stress dose to the stressor. Work the Cushing question in order. Check the medication list, confirm the excess, then localize, then image. On a pituitary incidentaloma, check the hormones and visual fields before anyone mentions surgery, and never forget the prolactin. And in diabetes insipidus, let every lab value eliminate an answer choice. To lock this in, drill the matching question bank blocks under timed conditions, and write down the trigger word that gave each answer away. That list becomes your high-yield sheet. Visit roadmaptoresidency.com for expert tutors and residency advisors. If this helped, please like and subscribe. Good luck on your exam, and we'll see you in the next video.